Hi, I am Dr. Prasanna Kumar, endocrinologist from Bangalore, and I have been working for the last 40 years in the field of endocrinology. I have done my DM endocrinology from All India Institute. I had 3 decades experience in the Department of Endocrinology, MS Ramaya Medical College. I have been the president of Endocrine Society, RSSD, as well as Indian Thyroid Society. I have more than 200 publications and 30 auditions. Why should I talk about atypical diabetes? Because I have got 65 centers, 4,000 children across the country who are getting insulin and all. Occasionally, we see many of these children have been wrongly diagnosed and they have been put on insulin when they can be controlled with probably a sulfonylurea and other drugs. That's why today we are talking of a atypical diabetes, which does not look like type 1 and type 2 diabetes, but recognize them in your practice by clinical as well as investigational method is very important. That's why I'm talking of an atypical diabetes, which is not very frequent but also not rare as well. That's why we will discuss about atypical diabetes today, which is nothing but a precision medicine where recognizing early, treating properly will help the patient and great relief to the patient with an accurate diagnosis and treatment. If we see diabetes and complication have reached in epidemic proportions globally, so the previous terms like juvenile diabetes, elderly onset diabetes, insulin dependent diabetes, non-insulin dependent diabetes, all of them have become obsolete. Today we talk of type 1 diabetes and type 2 diabetes only. So type 1 and type 2 diabetes are the one which are using, which accounts for nearly 90% of all the cases. What about the other 10%? Is smaller in magnitude but clinically significant subset of patients may develop diabetes stemming from a different pathophysiology. That's why what we are discussing today is atypical diabetes. So every clinician encounters a case of atypical diabetes, real challenge in recognizing it and also managing this is also a challenge. As our understanding of pathophysiology of diabetes evolves, we increasingly recognize that many patients may have a form of diabetes that does not really fit into type 1 or type 2. The binary categorization of diabetes into type 1 and type 2 is insufficient because there are so many other types of diabetes which are neither type 1 nor type 2 and they are called atypical diabetes. What is this atypical diabetes? It is likely to underestimate it and proportion varies anywhere between 5% to 11%. Let us start with a clinical scenario, then go through all the different types of atypical diabetes, and then we'll come back to this case. A 25-year-old man at his initial visit with you explained that he has had diabetes since he was the age of 17 years. His father and his only brother were also given a diagnosis of diabetes in their late teens. All are initially believed to have type 1 and they were started on insulin as initial therapy at the time of diagnosis. Their diagnosis seemed certain given their young age, lean build, with no signs of insulin resistance. However, your patient's insulin dose was always been unusually low, very small, 5, 6, 7, whatever it is, less than 10 units per day, with no basal insulin needed. His fasting blood glucose is usually below 6 millimoles, otherwise, we call it as less than 74. And he is able to miss insulin dose occasionally, especially if he eats low carbohydrate meals. He is prone to hypoglycemia when he increases his insulin or when he is exercising. No episodes of diabetic ketosis have been reported in this case. Now, on physical examination, he appears healthy, lean, BMI 22, and normotensive. He has no acanthosis nigricans, no evidence of diabetic retinopathy and neuropathy. As you know, acanthosis nigricans is a clinical marker of insulin resistance, which usually occurs in type 2 diabetes and obese patients. His A1C is 6.5. Normal for those without diabetes is less than 5.7. LDL 2.1 millimole. Target for people with diabetes less than 2.6. HDL 1.3. Target for men less more than 1 millimole. His father has recently stopped all insulin and is now doing well on low dose glimepiride therapy 1 milligram per day. The patient asks, Doctor, do I really have type 2 diabetes? He seeks your opinion regarding his diagnosis, prognosis, and management. So, thus, The atypical diabetes is less common but not less important. It is very, very important. What we call it as monogenic diabetes. The monogenic diabetes, non-syndromic forms of diabetes caused by single gene mutation. That's why it is called monogenic diabetes. Maturity onset diabetes of the young or MODY and neonatal diabetes are the two most well described forms of monogenic diabetes. What is the hallmark? A strong family history of diabetes with autosomal dominant pattern of inheritance with multiple affected generations. Meaning that if you take history properly from the patient, his father, mother, and his brothers, sisters, father's brothers, sisters, mother's brothers, sisters, three generations, if you take the history of diabetes for three generations, there will be history of diabetes. So this is the hallmark, a strong family of diabetes for three generations to diagnose monogenic diabetes. Affected relatives may be misdiagnosed with either type 1 or type 2 diabetes. So monogenic diabetes is estimated to comprise 6.5% of the pediatric diabetes population you should keep in mind. Especially if a person presents with a history of diabetes between 10 to 30, you must think of monogenic diabetes. There are various types of monogenic diabetes and neonatal diabetes. These are the one GCA, that is glucokinase. This is a full gene, and glucose are first rate limiting enzyme in that. And the clinical features of this monogenic diabetes with this GCK gene is stable, mild fasting hyperglycemia at birth, typically asymptomatic, diagnosis often incidental, but frequency of micro complications is very rare. HNF1 alpha or hepatocyte nuclear factor 1 alpha, and the gene function is beta cell transcription factor. The transient neonatal hyperinsulinemic hypoglycemia in some, progressive insulin secretory defect, OGTT, that is whole glucose tolerance test, frequently needed to make an early diagnosis, and renal glycosuria is common in them, and microvascular complications are common in HNF1 alpha. This third thing is HNF4 alpha, hepatocyte nuclear factor 4 alpha. The gene function is beta cells transcription factor. Birth weight usually more than 800 gram above the normal. That means the baby is big. Transient neonatal hyperinsulinemic hypoglycemia common. Progressive insulin secretory defect occurs, and microvascular complications are also common. The fourth type, what I am describing, is HNF1 beta, hepatocyte nuclear factor 1 beta, and the gene function is beta cell transcription factor. Intrauterine growth restriction, unlike the previous one where the child is poor, kidney abnormalities, urogenital tract infections, pancreatic hypoplasia, and they also have commonly microvascular complication which are not rare. Then the other genes is ABCC8 or KCNJ11. Then the full gene name is ABCC8 sulfonylurea receptor subunit of beta cell channel and potassium channel subunit. Very important because the children with this monogenic diabetes can be controlled with sulfonylurea. I have a patient who was on 3 times insulin, now controlled with sulfonylurea half a tablet. So gene function is closure of ATP potassium channel, leads to beta cell membrane depolarization, calcium influx, and fusion of insulin secretory granules with beta cell membrane. The clinical features can present with severe diabetes in the newborn period or present similarly HNF1 alpha and HNF4 alpha MODY, and frequency of microvascular complication are not known. Then CEL gene and carboxyl ester lipase, and there you have got exocrine pancreatic function, the gene function, pancreatic atrophy, exocrine pancreatic insufficiency, pancreatic fibrosis, and lipomatosis leading to diabetes. We don't know how common is microvascular complication. Neuro D1 or neurogenic differentiation factor 1, beta cell transcription factor. Usually they are overweight or obese, and again we don't know microvascular complication. The other thing is PDX1, pancreatic duodenal homobox 1, pancreas transcription factor, pancreatic agencies combined with pancreatic exocrine insufficiency and neonatal diabetes. INS gene, that is insulin gene, production of insulin or action, permanent neonatal diabetes. Also presentation similar to that of HNF1 alpha MODY or HNF4 alpha MODY. So, like that, we have neonatal transient diabetes or neonatal permanent diabetes. If diabetes occurs within 6 months of birth, it is usually neonatal diabetes. Remember that. And MODY is more common in after 10 years up to even 30 years we can recognize. So GCK MODY or MODY2, most common form of MODY, it results from heterozygous pathogenic variants of glucokinase, gene encoding glucokinase, and GCKs are the glucostat of the beta cell regulating insulin secretion. The clinical presentation is mild hyperglycemia with no common metabolic risk factors for type 2. History of A1C oscillating between pre-diabetes and mild diabetes level, not at increased risk of micro or macrovascular complication of hyperglycemia, as I told you. Do not require pharmacotherapy. Accurate diagnosis of this condition prevents unnecessary treatment of them. Then MODY3, HNF1 alpha MODY, it is the second commonest MODY, result from heterogeneous pathogenic variants in hepatocyte nuclear factor 1A, that's why it is called HNF1 alpha, important beta cell transcription, often develop insulin deficient diabetes in the second and third decade of life. Microvascular complication of hyperglycemia are common, often successfully treated with sulfonylurea if recognized early. This is what I told you. I had a 14-year-old girl, now she is 28, and now she is treated with sulfonylurea. Recognition of one family member with HNF1 alpha MODY can inform cascade testing in family members. MODY3, this is what you see, clinical consideration lab features. Autosomal dominant inheritance, as I told you, often more than 3 generations with diabetes. History taking very important. And C-peptide is detectable and it has high penetrance in family. Islet cell antibodies usually absent. European ethnicity most common, normal triglyceride levels, but India also we have seen this. Lean body mass less than 25 Europeans, less than 22 for Indians. Normal or high HDL cholesterol levels, usually, as I told you, less than 25 years. Low C-reactive protein level is high sensitivity testing. Usually they don't go to ketosis. Even with 250, this girl came to me 10 years back. She had no ketosis. That made me, family history of 3 generations, father, mother, grandfather had no ketosis. I thought this is the one. I didn't start insulin and we were able to manage sulfonylurea. Low renal threshold of glucose, glycosuria often occurs when serum glucose is 8. That means more than 104 also. Then increased insulin sensitivity. Patients often have minimal requirement of insulin and large more than 3 millimole rise in 2 hours glucose levels on 75 gram glucose GTT. Hypersensitivity to sulfonylurea drug for up to 50%, fasting glucose is less than 5.5 millimole. To convert millimole to milligrams, you multiply by 80. Postprandial hyperglycemia is the one which dominates. Prevalence of micro and macrovascular complications similar to that of patient with type 1, and there is a progressive beta cell failure over time with increased fasting. So these are the things you should keep in mind with HNF1 alpha MODY that is seen. Then neonatal diabetes. As I told you, it is a rare disorder, 1 in 90,000 to 1 in 4 lakh. In the last 40 years, I have seen many of them. And usually in neonatal ICU, you can see this. NDM arises from a single gene mutation that affects pancreatic beta cell development, function, and persistent, as I told you, transient and persistent neonatal hyperglycemia. Persistent hyperglycemia typically diagnosed in the first 6 months of life. Neonates present with severe hyperglycemia and ketosis if not diagnosed early. Approximately 25% of the cases are transient and resolved by 6 to 18 months. What happens when the children are born? The enzymes have not yet matured. As the child grows, the enzymes which are necessary for the metabolism of the glucose, they mature and disappear. That's why it is called as transient neonatal hyperglycemia. Whereas 75% are permanent, and as I told you, it is because the pancreatic beta cell development function are affected. Severity of the varies between transient metabolic dysregulation to severe forms of the neonatal diabetes. How to diagnose the neonatal diabetes? May have a history of intrauterine growth retardation or low birth weight due to insulin deficiency in utero. Symptoms like polyuria, tachypnea, irritability, lethargy, hypovolemia are non-specific and difficult to recognize because they are small children. They can't tell you that. Infant with permanent neonatal the diabetes as such, monogenic diabetes due to pancreatic aplasia or hypoplasia may present with malabsorptive diarrhea due to pancreatic exocrine insufficiency. When you do ultrasound or CT, you will see the pancreatition or not even seen. So how to work up this child? Evaluation of alternative etiology, measurement of C-peptide and insulin plus decay assessment, islet cell antibodies, insulin antibodies, IA2 antibody, GAD65 antibody, zinc transporter 8 antibody should be measured to exclude type 1 diabetes in patients aged greater than 6 months. Ultrasound, as I told you, or CT or MRI, there is agenesis of pancreas. Most important when you do fecal elastase, which is the diagnostic test for pancreatic exocrine insufficiency, and this fecal elastase test will make the diagnosis the child has got a pancreatic exocrine deficiency. Because when you do that test, fat malabsorption will be known. The syndromic diabetes are present with the atypical clinical features. In addition to hyperglycemia, it arises from a single molecular defect, as I told you, HNF4, 1 alpha or 1 beta. More severe condition may result from de novo mutational events, thus appearing to be sporadic rather than familial. Genes responsible for syndromic forms of diabetes often encode proteins important for beta cell development, function, and survival. Because these are the important coding proteins. If they are abnormal, then beta cell development, function, and survival will be affected. This is another thing not very uncommon. I had at least 12 cases of Wolfram syndrome, also known as diabetes insipidus, diabetes mellitus, optic atrophy, or deafness. It is called Didmore syndrome. That's why diabetes insipidus, diabetes mellitus, optic atrophy, and deafness caused by biallelic pathogenic variants, that is Wolfram S1, WFS1, or CSID2, and segregates in families in an autosomal recessive pattern, often present below the age of 16 years with antibody negative insulin deficient diabetes. I had a family, unfortunately, both the elder brother and elder brother, both of them had this disease. I had a girl with this, she died at the age of around 25 due to renal failure. So this is how their lifespan is limited. I have not seen any of my patients with Wolfram syndrome going beyond 30-35 years. They soon develop optic atrophy and can have additional features of sensory neural hearing impairment, diabetes insipidus, urinary tract abnormalities, progressive neurodegeneration, psychiatric disorders. One of my patients has a very severe psychiatric disorder. The mother felt extremely difficult to manage this child. Individuals with Wolfram syndrome due to CSD2 variants tend to be more severely affected and may additionally develop gastrointestinal bleeding. Risk of lactic acidosis, arrhythmia, pancreatitis, and ketosis are important to consider in them. Then we have got cystic fibrosis related diabetes. Again, this is a different type. What are the features and how you compare it to type 1 and type 2? Underlying pathophysiology in type 1 is insulin deficiency. There is extreme insulin deficiency, whereas in type 2, it is primary insulin resistance. And as the resistance increases, the insulin insufficiency also sets in progressively. Whereas in cystic fibrosis, primarily insulin insufficiency with features of insulin resistance. That means it has got both. Exocrine dysfunction is absent in type 1, absent in type 2, but present in cystic fibrosis. As I told you, the test of pancreatic exocrine insufficiency is the one which will diagnose it. Risk of ketosis common in type 1, rare in type 2, rare in cystic fibrosis also. Microvascular complications are common in both type 1 and type 2, but also seen in cystic fibrosis related, but they are usually milder. Treatment for type 1 is insulin, type 2 it is usually lifestyle modification, oral antidiabetics, GLP-1 analogs. Ultimately, when insulin resistance leads to progressive insulin deficiency, they also need insulin late, whereas cystic fibrosis need insulin from the beginning. Dietary guidance, well balanced diet for type 1 and low calorie balanced diet for type 2 with low carbohydrate content, whereas for cystic fibrosis you need high calorie, well balanced diet, account for carbohydrate consumption also. This is how you can differentiate cystic fibrosis related diabetes and when compared to type 1 and type 2 diabetes. There are other forms known as lipodystrophic forms of diabetes, clinically characterized by loss of body fat, which may be generalized or limited, known as partial lipodystrophy or total lipodystrophy. This is what you see in them. All over the body, some of them don't have 1 gram of fat, starting from face, buckle, cheek, neck, everywhere. They look something like very, very thin, and there's no fat anywhere, and they really look as if malnourished or something like that. Prominent musculature, rhipomegaly, severe hypertriglyceridemia, and profound hepatomegaly resulting from steatohepatitis. So these are the diseases and onset, whether it is infancy or body fat absent or not, and metreleptin is the one FDA approved drug. And this is how you see the different types of the what you see it as lipodystrophic forms, and when it infancy, adolescent, or childhood, and how body fat is absent, then it is absent in FPLD, in limbs, buttock, and hips, and in others it may be variable. And this drug, metreleptin, is approved by FDA for CGL variety and also for AGL. Otherwise, other category, these things are not approved as such. Then latent autoimmune diabetes, known as LADA, latent autoimmune disease of the adult. So presence of islet cell antibody, but absence of insulin deficiency for at least 6 months after initial diagnosis of diabetes in adults. We have many patients, they come with diabetes, you start treating with oral anti-diabetic because they typically look like type 2 diabetes. Within 1 or 2 years, they need insulin. Then you start thinking, why is it they need insulin? Because they have a islet cell autoantibody, the beta cell will regenerate fast. So often initially classified as type 2, frequency of LADA in codes of type 2 varies between 5 to 13%. LADA represents a pathophysiologic overlap between type 1 and type 2. So LADA is likely underdiagnosed in clinical practice. Remember, most often when you see very young 15, 16 below that ketosis, they are type 1. 40, 50, they are most of them are type 2. But there is a gray zone anywhere between 20 to 30, 35. If you check the antibodies of diabetes, whether it is GAD antibody, islet cell antibody, whether it is an insulin autoantibody, zinc transport antibody, if they are positive, LADA is likely in those cases. So it is underdiagnosed clinical practices. Physicians infrequently measure islet cell antibody in adults who do not appear to require insulin therapy at the type of diagnosis. So if somebody is there, like type 2, well controlled, if you do antibody positive, you can tell him that your chances of going to insulin is very high within 2 to 3 years. Widespread anti-antibody testing in patients, especially non-obese type 2, could improve the diagnostic yield as such. Then you have got ketosis-prone diabetes. Decay presentation in the absence of characteristic features of type 1 diabetes, both clinically and etiologically. It is ketosis-prone diabetes heterogeneous. There are 4 distinct subtypes of ketogenic-prone diabetes, which has been defined on quantitative measurement of antibody positive or negative, A positive, A negative, B positive, B negative. These are the 4 types of KPD or ketosis-prone diabetes. That A positive, B negative KPD most closely aligns with features of traditional autoimmune type 1. A negative, B negative KPD also resembles type 1 but does not have detectable islet cell antibody. Recently, I had a medical student where we did all the tests, the GAD antibody, islet cell antibody, insulin antibody, zinc transport, everything negative. So she fits into A negative, B negative, the ketosis prone diabetes. She had mild ketosis. She was admitted in the hospital. She was all right after 2 days, and she is not using very high dose, very small dose of insulin as such. Then there is the worst type of diabetes, what is known as fulminant diabetes. This was first described by the Japanese. Very sudden onset with patient presenting usually with decay, but with normal or near normal events at diagnosis. I have shown only one case in 43 years of my practice. Reported frequently as type 1 diabetes. The patients often lack typical type 1 associated islet cell antibody and HLA allele. Unlike LADA, patients experience rapid destruction of beta cell within weeks. So there is no time for HbA1c to rise. Within days or weeks, the get the diabetes. That's why A1C will not be 8, may be normal. But you will see that patient is in ketosis. This results in discrepancy between their current blood sugar state and their HbA1c. If somebody presents with DKA, A1C is 6.5 or less, please suspect fulminant diabetes. And the prognosis can be bad if you don't treat them very, very intensely. Then there is one bronze diabetes. How do they present? A 15-year-old, 51-year-old male presented with a diagnosis of type 2 diabetes, A1C 7.8, not very high A1C like type 1, family history negative, and patient has hypertension. He was on metformin 1500 milligram, BMI 31, obese, waist circumference 112. Patient's skin appear reddish in color. That's why it's called bronze diabetes. Then patient's hemoglobin 18.6. You will see high hemoglobin in smokers, COPD, asthmatics. Otherwise, if you see anybody's hemoglobin next more than 16, you should suspect something wrong here. Hematocrit is 53% high. Increased plasma ferritin. Why in a patient who is not taking anything, it is 945. Saturated transferrin fraction, more than 54%. Transferrin 255 microgram. It is consistent with the diagnosis of hemochromatosis. So genetic analysis showed homozygous mutation for H63D in HFE gene. So these are the things what you see, whether it is neonatal transient, neonatal permanent, bronze diabetes MODY. There are 13 different MODY, 1, 2, 3, 4, 5. I have shown you some of them. So what should be the approach to patient with atypical diabetes? This is the algorithm. When you diagnose diabetes, known underlying condition, like we didn't discuss genetic factors like genetic diabetes, mitochondrial disease or CF, medication related to hyperglycemia as it's atypical or medication induced diabetes. Then family history is suggestive of atypical, maternal diabetes, deafness, consider mitochondrial diabetes evaluation. Then if we see age less than 25 diabetes, yes, beta cell autoimmunity, please check GAD antibody, islet cell antibody, insulin autoantibody, zinc transporter. If they are positive, 1 or 2, type 1 diabetes. If negative, age less than 12 months, atypical diabetes evaluation, that is mitochondrial diabetes. BMI less than 25 or not. Then you see atypical features like renal disease, liver disease, pancreatic exocrine insufficiency like chronic diarrhea, gastrointestinal malformation, gout, autism, adrenal insufficiency, structural heart disease, cardiomyopathy, encephalomyopathy, ataxia, deafness, Dias insipidus, or cerebellar hypoplasia, or epilepsy, neonatal hypoglycemia, then optic atrophy, renal dystrophy, cataract, ophthalmoplegia, retinitis pigmentosa. Then think of these things because I had a patient where he had a retinitis pigmentosa. Now he's almost 40-year-old, totally blind. So this is what you see some of the syndromes. He also had hypogonadism as such, hypertrichosis, hypoparathyroidism, hypomagnesemia, prepubertal position. So that is how you see many of these syndromes like Prader-Willi syndrome and others have these things. If none of them are there, it is type 2. So you have got at the top on the right side, atypical or medication induced, on the left type 1 antibody positive, on the right, none of these atypical features, it is still type 2 diabetes in the young. So this is how the diagnostic algorithms for them. So if you see diagnosis less than 6 months, test for these genetic testing, that is KCNJ11, ABCC8, and insulin gene, other neonatal genes. And if it is type 1 diabetes, family history is suggestive of monogenic diabetes, no history of DKA, GAD antibody negative, prandial postprandial, the plasma C-peptide more than 200 picomole, urinary C-peptide, creatinine ratio more than 0.7, less than 6 months, this is what you see. Then more than that, you look at others. The atypical, we have already discussed how absence of obesity, hypertension, and PCOD, acanthosis nigricans, that is type 2. This is what you will find out. Then fasting glucose, A1C, and these are the tests for GCK, that glucokinase gene. And if we see familial, more than 3 family, sensitivity to sulfonylurea, HNF1 alpha, if negative test for HNF4 alpha, if the patient has additional feature like deafness, maternal deafness, and also maternal diabetes, pigmentary maculopathy, myopathy, stroke, check for MIDD. And if the patient has renal cyst, abnormal liver function test, genitourinary abnormalities, exocrine dysfunction test for HNF1 beta. This is how, when you see that it is not a typical type 1 diabetes and there's family history less than 6 months, more than 6 months, and less than 6 months, what genes to test? If it is typical type 2 or atypical type 2 diabetes, then which gene to test? This is all. Nowadays, you have a panel. If you think Modi, just send them. They are checking almost 38 to 46 gene. They will come out. Whether you do 1 or 2 tests doesn't matter. They do a whole panel of Modi panel. Most of them charge anywhere between 16 to 20,000, and you will get all the ingested. Even if you are not sure what it is, not like you test 1, 2, 3, you will get the diagnosis. So clinical tests that help identify, classify atypical diabetes are measure clinically reliable markers of islet cell autoimmunity, beta cell function, insulin sensitivity, and genetic variants underlying known forms of monogenic diabetes. Islet cell antibody, as I told you, most common autoantibodies in people with autoimmune diabetes are autoantibodies against GAD antibody, GAD65 antibody, islet cell antigen 2 known as IA2 antibody, insulin antibody, zinc transporter antibody, or ZNT8. I had a machine where in 20 minutes I could get GAD antibody, islet cell antigen 2 antibody, and also C-peptide. And it has been very useful when the patient comes. Within half an hour, I could get the 2 antibody C-peptide diagnosed. Last few years, I'm using. It's a great advantage. Point of care test. You don't have to wait a day, week, or month. Within 20 minutes, you can get all the 2 antibodies plus even C-peptide. Antibodies against insulin may be unreliable for patients already treated. Somebody keto has started insulin. Don't do insulin antibody. You can do other 3 antibodies. And also depends. GAD antibody is the one which lives longest, many times 1 year. Zinc transporter lasts hardly 6 months. After that, unlikely to be present. And IA2 antibodies, which may not be seen in everybody. So in our study, which we published, that zinc transporter are more common positive compared to the islet cell antigen 2. Autoantibody positive may wane with time. Hence, it is important to try measure these when a patient is first diagnosed. That's why I told you GAD antibody lasting longest, zinc transporter up to 6 months. High titers of multiple islet cell autoantibodies strongly suggest autoimmune forms of diabetes such as type 1, LADA, or A positive subtype KPD, ketosis prone diabetes. Measure serum insulin C-peptide level as a marker of patient's endogenous insulin capacity. As the half-life of insulin is very short, 4 minutes, we don't measure insulin, we measure C-peptide, whose half-life is 20 minutes. Because for 1 unit of insulin, there is 1 unit of C-peptide. So it's the best marker. Serum C-peptide can reflect residual beta cell capacity. Insulin, C-peptide, glucose data from OGTT allow endocrinologists to calculate range of indices of insulin secreting capacity known as C-peptide index. So if you have facility, you can do. So C-peptide index less than 0.245 suggestive of insulin deficiency. OGTT and mixed meal tolerance. It's not just glucose tolerance, mixed meal, like what you take breakfast, lunch, and dinner. MNTT can also provide indirect evidence of insulin resistance if the stimulated C-peptide remains high throughout the 2 hours test, presence of sustained hyperglycemia. One OGTT or mixed meal tolerance test is not feasible. Insulin dose adjusted A1C, IDA A1C measurement can be helpful for surrogate marker. IDAAC less than 9 corresponds to predicted stimulated C peptide of more than 0.9 nanogram per ml and partial recovery of beta cell function. So even if you take baseline or stimulated C peptide, then we can make our diagnosis of type 1 or type 2. Online probability calculators are available to aid clinical decision making. Now I got so many apps for calculator. Enter age at diagnosis, BMI, insulin requirement, A1C into calculator, obtain a value that indicates patient's likelihood of having monogenic diabetes. 36% probability with a positive predictive value of 74.4% in using what is known as Exeter Modi probability calculator. Exeter University in UK, they are the one who are developed. In the case of pancreatic diabetes, patients may have low fecal elastase. As I told you, fecal elastase is a test used for pancreatic exocrine insufficiency. If fecal elastase is absent, fat will not be absorbed. That's why its level will be very low. For patients with insulin-resistant forms of diabetes, it may be important to rule out Cushing's disease, measuring 24-hour urinary free cortisol, measuring midnight salivary cortisol, or performing low-dose dexamethasone suppression test. I don't want to go into that details because it will cumbersome and takes more time. So the precision approach to atypical diabetes. What we are coming now from trial and error treatment of diabetes to precision diabetes. Why? You can diagnose type 1 diabetes day 1. You can diagnose type 2 diabetes day 1. You can diagnose LADA, late onset adult autoimmune deficiency disease, LADA on day 1. And you can also diagnose monogenic diabetes in few days. And category, whether monogenic diabetes, neonatal diabetes, or syndromic diabetes. GCK modi, HNF1 alpha modi, HNF4 alpha modi, HNF1 beta modi, ANDRAS modi. And treatment, GCK modi not necessary, HNF1 alpha, sulfonylurea, GLP-1 receptor, SGLT2, insulin, HNF4 alpha modi, sulfonylurea and insulin. That means this is precision diabetes, not a trial and error method. So also HNF1 beta modi, you can use sulfonylurea and insulin. Other modi likely to require insulin, and all of them have low incidence of microvascular complication. And neonatal diabetes, ABCC8 may respond to sulfonylurea. KCJ11 also may respond to sulfonylurea, and you have to monitor them. METs need insulin, NADH need insulin, WOCKHART syndrome, Michel-Relay syndrome, IPEX syndrome, and Wolfram syndrome, as I told you, the Didmore syndrome, all of them need insulin. Like if a patient has diabetes insipidus, optic atrophy, deafness, clinically you can make a diagnosis of Wolfram syndrome. Other things, as you know, as per this slide. So mitochondrial diabetes, MIDD, MELAS, and Lee syndrome, all of them need insulin. Metformin is contraindicated because it can cause lactose suspension. Lipodystrophies, I told you, CGL, FPLD, and progeroid lipodystrophy, AGL, all of them are treated with metformin. Then also use sulfonylurea, thiazolidines, if necessary, later on insulin. And ketosis prone, AB positive, A positive, B positive, you need metformin. Later on insulin, A negative, B positive, metformin, insulin may be needed, and A negative, B negative, insulin may benefit from. Insulin is the treatment, may benefit from the metformin as such. LADA is always insulin, but initially they may respond to all antidiabetics for that. Pulmonary diabetes is the worst. From day 1, you need insulin, rapid B cell destruction, hyperglycemia, but A1C is out of proportion to blood sugar. So severe insulin resistance syndrome, I'll not go into detail. Donahue syndrome, Robinson-Mendelhorn syndrome, type A insulin resistance, type B insulin resistance, insulin autoimmune syndrome. So these are the one in Donahue syndrome treatment IGF-1, in Robinson-Mendel metformin later and glitazones and IGF-1, and type A insulin resistance you need metformin, glycoside, this thiazolidines, GLP-1 receptor analog insulin, whereas in type 2 you can use corticosteroids, metformin, HCQ, and methotrexate. Then you see that in Donovan syndrome, there is growth restriction, short stature. In Rabson-Mendelhab, they have severe acanthosis nigricans, and type A insulin, what we see, severe PCOD may require high dose of insulin. Many of my PCODs are having this. And in type 2 insulin resistance, paraneoplastic syndromes of connective tissue are important. In pancreatic diabetes, what we call type 3C, insulin is necessary because the beta cells, pancreatic islet cells are not functionally well, and exocrine dysfunction also. You have to manage diabetes with insulin, manage pancreatic exocrine deficiency with the early enzyme. So coming back to the pancreatic enzymes, you have to replace if they have got this syndrome of pancreatic diabetes or type 3C diabetes. Coming back to our case, 25-year-old man at his initial visit with you explained he has had diabetes since 17 years. Father, only brother were also given diagnosis of diabetes in their late teens. All were initially believed to have type 1 and was started on insulin therapy initially, and the diagnosis seems certain given their young age, inbuilt no signs of insulin. However, patient's insulin dose has been less than 10 units per day with no basal insulin needed. His fasting glucose is usually below 6 millimole, that means 84 milligrams, and is able to miss insulin dose occasionally, especially if it's low carbohydrate meal. He is prone to hypoglycemia when he increases insulin or when he is exercising. No episodes of decay have been reported. On physical examination, appears to be healthy, lean, normotensive, no acanthosis nigricans, no retinopathy, neuropathy, A1C 6.5, and you see that LDL cholesterol is good, HDL cholesterol is good. Father has recently stopped insulin, now doing well on low dose glimepiride. Patient asked the question, I showed you initial slide, do I actually have type 2? He seeks your opinion regarding diagnosis. This young lean man has all features concerning diagnosis of HNF1 alpha monogenic diabetes, strong multi-generation history of early onset diabetes, minimal requirement of insulin, optimal fasting glucose control, no episodes of decay, signs of insulin resistance, and HDLC level inconsistent with usually low seen in diabetic dyslipidemia. Father has responded well to low dose sulfonylurea in keeping with the heightened sensitivity to these agents that has been observed in HNF1 alpha diabetes. You should be told it he has an unusual form of diabetes that is strongly inherited. Generic testing of common HNF1 alpha mutation is commercially available, as I told you, could be offered to confirm the diagnosis. His risk of developing long-term complication is similar to those with type 1 diabetes. He can be switched from insulin to low-dose whole sulfonylurea should be counseled as to the potential impact of his diagnosis on future family planning. So at the end of this 35 minutes talk, what is the take-home message? Recognition of patient with atypical diabetes is important because the therapeutic and prognostic implication. It is not just an academic exercise. Patient treatment can change from multiple doses of insulin, one tablet of sulfonylurea, or mild diabetes need not be treated like some of them. Patients have been misdiagnosed with type 1 or type 2, in some cases committed to unnecessary insulin therapy and screening for complications. Providers should be suspicious of atypical diabetes, particularly in youth with a known condition that confer risk in youth who lack both islet cell autoantibodies, classical signs of type 2. Strong family history of diabetes and conditions associated with atypical diabetes also are features that may prompt additional testing. Comorbidities, like I told you, deafness, hyperinsulinism, renal disease, liver disease in a patient with new onset diabetes should prompt consideration of atypical diabetes, like I told you, Wolfram syndrome, where there is optic atrophy, deafness, and such things. And also renal disease, liver disease, some of the moody. Appropriate treatment, proper management of atypical forms of diabetes are contingent upon the correct diagnosis. MODY is most commonly caused by a mutation in the gene encoding hepatocyte nuclear factor 2 alpha. Initial treatment is low dose sulfonylurea therapy. MODY caused by mutations in the gene encoding glucokinase does not require treatment outside pregnancy. Type 1 diagnosed before 6 months age should prompt screening for neonatal diabetes genes which may lead to discontinuation of insulin therapy. Ketosis-prone diabetes should be considered in patients present with ketosis and type 2 phenotype. LADA can be considered as slowly progressive type 1 diabetes. That's why I told you within 2 to 3 years they get insulin and tablet no longer work. Maternally inherited diabetes and early deafness are clues to the possibility of mitochondrial diabetes. Genetic molecular testing is available commercially or in many of the academic institutions. Patients should be referred for such specialist assessment. Thank you for your attention.